Hello, everyone. My name is Nathaniel Bischoff, and I am the Fellow in Artificial Intelligence and Medicine for Chalk MI3. And it is our pleasure to put on our first AI Med Beach, the pitch event here at AI Med. So I'm going to have each of our judges introduce themselves, and then we'll go ahead and get started with our 5 companies that will be pitching tonight. Thank you.
Hello, I'm Karen Drexler. I'm currently CEO of Sandstone Diagnostics, a company in the men's health space. Our first product is a home male fertility testing system where we help guys understand their fertility status and provide them with data and personalized coaching to improve their fertility outcomes. But probably more relevant for this panel, I'm also a founding member of a group called Astia Angels, which focuses on funding high potential female founders. Delighted to be here and welcome everyone. Arlen?
I'm Arlen Myers. It's a pleasure to be here, and I'm the president and CEO of the Society of Physician Entrepreneurs. We're the largest physician entrepreneurship network in the world.
Okay, go ahead.
I am Dan Gebermedin. I'm a principal at Flair Capital Partners. We have a $200 million early stage health tech and services venture fund based in Boston, Massachusetts. I'm also a trained physician practicing internal medicine at the Massachusetts General Hospital. I've also spent time as a health IT entrepreneur and a payer executive.
Good evening. My name is Frank Chen. I am the project manager at Santen Pharmaceuticals, a ophthalmic pharmaceutical company based out of Osaka, Japan. More specifically, my group is the innovation office, partnering with startups as well as investments.
Hello, everyone. My name is Amir Beni Fatemi. I work with XPRIZE, which is XPRIZE Foundation, and manage the AI initiatives there. And also managing partner of a fund called K5 Ventures and long-term investors in Southern California.
And I'm David Friedman. Good evening. Hope you enjoyed tonight's Shark Tank. I am part of Tech Coast Angels. I'm the screening chair for TCA OC. We're the largest or second largest angel group in the country. I've been invested probably around $200 million in angel deals over the last 20 years. So I hope you enjoy it tonight.
Okay.
Thank you. So just so you know what the contestants are competing for, the grand prize is the silver sponsor. It's a $25,000 value that includes speaking at next year's conference, a speaking opportunity, 2 conference registrations, 2 stays at the Ritz-Carlton, and an exhibitor booth. The second place, the bronze sponsor, is a $10,000 value, includes a speaking opportunity, 1 conference registration, 1 stay at the Ritz-Carlton, and an exhibitor booth. And finally, last but not least, third place, a $3,000 value that includes 1 conference registration and an exhibitor booth. So pretty good for startups and a great opportunity to show your wares. So without further ado, we'll introduce our first contestants.
Indeed, we have 5 exciting companies to share with you tonight. Our first company is Oncoverse. Oncoverse is working in the very complex area of cancer management, helping to have all of the clinicians that are involved on a on a management team come together to support the patient. So Oncoverse, please.
So each contestant will get 5 minutes to present their pitch, and then we'll have 5 or 10 minutes of questions.
Thank you for that introduction. Hello, everybody. I'm Amanda Goltz, and this is Oncoverse. In a nod to my investor judges, I will briefly say that Oncoverse is a privately funded startup and a joint venture with health system Dignity Health. And its total addressable market is all accredited cancer centers in the United States. And the primary business value, we think at this point, is to scale many of the AI solutions that we've been hearing about today and bring them to market and put them into clinical practice. So the rationale behind Oncoverse is something I'm going to describe in a moment, and then I'm actually going to show you the product. I'm not a big believer in slideware. I want to actually show you, as a majority physician audience, how it might work in the very complex cancer treatment process. And I'm also very inspired by what we just heard from one of our faculty members, Christina Chen, about the clinical story. We've had a lot of debates about whether AI will replace the physician or what the respective roles should be. I think there's a certain amount of physician expertise, intuition, knowledge of the patient that cannot be replaced. The challenge is to put it in context with the findings of the AI. So we worried about three things when we were coming up with Oncoverse. Number one, how do we put recommendations made by machine learning algorithms or AI in the context of an existing physician-to-physician conversation? So we thought about the tumor board process that all accredited cancer centers must go through for 15% of their most complex cases. Number two, we thought a lot about future AI to AI interactions, AI to human interactions, and of course the existing physician to physician, human-human interactions of cancer planning today. Third, we worried about data that is not yet digitized and thus cannot be consumed by the AI, such as the patient's response to their cancer diagnosis and their plan to adhere to recommended treatment, their preferences, their biopsychosocial circumstances, and their life setting. So we set out to solve all of that. No problem. We did it in like 2 days. It was really easy. So behind me, you see Oncoverse. The physician would log in here. It is a secure, HIPAA-compliant platform for oncoversing, conversing about oncology, if you will, and it aggregates all the data related to a case, clinical, diagnostic, imaging, precision medicine, genotyping, phenotyping, patient-reported data, and any relevant AI or machine learning insights into one place so physicians can see it with each other, talk about it live synchronously or asynchronously at any time they like, and share their conversation with one another. So we were on the presenting cases dashboard. I think we want to go to evaluating cases. Where are my cases? I think this is a lesson in HIPAA saying do not show this data to anybody else. At any rate, you'd see a dashboard listing the cases that you have been asked to consult on or that are your patients. You would click into them, and you would see a list down the left-hand side that would allow you to see EHR integrated data, the clinical case history, the medications that the patient is on, the radiology report and clinical grade imaging itself, as well as a patient survey of structured data about what the patient thinks about their response to treatment and their capabilities to adhere. You would then issue a treatment plan that you would author yourself and enter onto Oncoverse. You could also do an alternative plan if you wish to deviate from the guidelines based on some recommendation from the AI or your own intuition. Your consulting physicians would view that, both your recommendations and all the other clinical data, and they would respond with their own plan. All of those plans come back to the presenting physician, the medical oncologist, whoever is in charge of that patient, and then they synthesize, based on their own judgment, what should actually happen to that patient. And then that becomes the treatment plan. It's exported into the order set. And you can see how this would be a presentation layer for many AI solutions for physicians to be able to leverage them. You can also see how this would begin to feed back data into the learning system as a carrier wave for all of these different pieces of information so that you can see what types of collaboration were most effective in generating better outcomes. So right now, you see it all going on behind me. There, I'm clicking into a video call if I want to have an instant remote consultation with one of the physicians. I can see supporting studies and reports. I can see the treatment plans from each of the physicians that I'm consulting with, anybody who is accredited at my hospital center or has access to my EHR. And then I also have a chat function, which we can see here, which is, I have a question, I need clarification, I need to understand something. So we focused very much on the communication piece because we thought that was the physician conversation, but Oncoverse is handling it for you.
Okay, wonderful. Well, thank you so much. We have some questions for you, so don't leave yet. We'll have a few minutes to ask questions of each of the companies, and maybe I'll just kick off and ask you about the stage. So where are you in rolling this out? And just give us an update about that.
Absolutely. We have an enterprise contract with Dignity Health with all 30 of their hospitals. We have set enterprise pricing. It's a SaaS pricing model. And we have clearance from IT for the entire enterprise. So the rollout plan is to each of the 8 service centers in turn, and we've already identified our clinical champions.
Okay.
All right, so I enjoyed the presentation as a non-clinician, but as a potential user on the other side. It would be interesting, but when I look at it, I didn't hear the real investor pitch. I heard it's a product pitch. I got it. I understand it. It's very visual. I don't see the AI part. I don't understand the business model. I don't understand where you're going to take it, and I don't know if I'm an investor in your business, I'm not sure what I'm really investing in. It would also be interesting to know more about yourself and about the team, how much you want, what's the next stage of growth. So there are a lot of empty holes that need to be filled in somewhere, or make sure you present it so that you'll get those questions asked, either one of the two.
Absolutely. And happy to answer those if you're interested, briefly.
Sure, please.
Okay, great, sure.
Take one out of the top 10.
One or two.
Perfect. Let me see where to start.
Tell us about you.
Sorry.
You can tell us about you.
Oh, me, yes. So Oncoverse, as I mentioned, is a joint venture between two entities. One of them, of course, is Dignity Health. This is a germ of an idea from intellectual property of one of their physicians. The other side of that table is the commercial partner, which is the company I actually work for in my day job. That company is called BTG. It's a medical device therapeutic company based in interventional oncology. And the opportunity that BTG saw in this is a way to supply all of our interventional oncologist customers with a way to access tumor boards so that they would be brought into the consultation on the patient farther upstream and, of course, then leverage our products. The business opportunity for Oncoverse qua Oncoverse, though, I think is number one, in a sort of immediate sense, to meet that accreditation requirement that cancer centers have to attest that to the ASCO guidelines that they have reviewed their most complex cases in this format, as a way of leveraging and ensuring that their physicians are following clinical guidelines. Third, as a way, if they have distributed networks or an academic medical center has affiliated with community networks, to ensure that the level of care practiced at the AMC is filtering out into the community and that the community oncologists have access to those resources, those academic tumor boards. And then in the future, what I mentioned is a way of bringing to market those AI solutions. So what you could imagine surfaced in this would be those findings, recommendations, the computer vision on the radiology piece saying, here's what I see compared to the last 2,000 lung screenings. This nodule is questionable, look at it. Or it could simply be, for the last 20 patients for whom this particular regimen was tried, didn't work out so well, try something new.
Okay.
I have a question about your product value proposition. I think you've been very thoughtful in digitizing a lot of existing analog communications that are happening, and you articulated that the key value proposition, at least today, is attestation compliance with the ASCO requirements. Is there a way to quantify, the improvement in outcomes? Through the use of your tool, the expected lift above existing outcomes that are happening today in an analog format?
I think it's a really fascinating question, and I think it's one we struggle with. The current baseline outcome for cancer care is mortality. Did we extend life? And we've already heard today themes about, can you extend health, and how does that measure out? Is it in tension with extending mortality? Are there measures of functional status of the patient that we should really be focusing on improving rather than just trying to extend life as much as we can? I think there's some work to be done on defining clinical value that Oncoverse could then mirror back. If you tell it what the measures of improvement should be, then it could analyze in the background for this level of collaboration or for these physician treatment choices, this is how much better the outcomes got for this segment of a population. But again, we come back to the human. It has to be told what the desirable outcomes are.
So I'm a head and neck cancer surgeon, and so I spent a lot of time in tumor boards, and the literature seems to reflect that the outcomes of tumor boards are not what we would like. In other words, you may confirm the diagnosis, but there are vast variabilities in treatment, and when you actually look at this question, the outcomes don't change in terms of reflecting evidence-based guidelines. Bottom line, tumor boards don't work. So if you believe that and you digitize tumor boards don't work, how does that change the impact?
I think our hypothesis was that indeed tumor boards don't work, but they don't work today because the right data is not brought to the table, and that all the physicians consulting don't have access to the data that they would want on the patient at that moment to have that conversation. So it was that type of information availability, data in context, understanding how to make those guided decisions that we thought would enrich the tumor board context and make it better. Now, you could take it entirely out of the tumor board context, right, and just make this a remote consult platform. And then you'd be sucking up a ton of brilliant minds around cancer and bringing them to bear on any patient anywhere. It could be seen in that context as well.
Other questions?
You talk about decision support. Can you elaborate a little bit of your possibilities with AI if you had to implement it today, and what would be the requirement to implement it?
How to bring AI solutions into the platform?
Yeah, because you're basically focusing on decision support
Sure.
and compliance, but decision support mostly. So because we're talking about AI and man and machine, what would be, if you had to implement it today, because you said you're going to do it later on, what stops you from doing it today?
Absolutely nothing. I think what we're trying to figure out is how do we leverage this point at which we know physicians are having a physician-physician interaction and then draw the AI into it. So what we've seen with other IT implementations, some unrelated to IT, when you bring clinical decision tools into the clinical workflow, sometimes you get a great effect, sometimes you get things like alarm fatigue, people ignoring it, people circumventing it, people having one bad interaction with it and then never using it again. So the only thing I think that's constraining us at the moment is what are the right solutions to bring into the platform, knowing that as soon as we expose them onto the platform, there's no ability to say, I don't want to use that AI tool, I do want to use this one. So I think we're looking for a little bit of best of breed, we're looking for what really has clinical value, and we're looking for what do the physicians at that hospital want to practice, given local practice patterns.
Maybe what Arlen said earlier on would be a good initial starting point to evaluate the data sets that would actually deliver value, and it can be a proof point before you go to a more workflow.
And the follow-on question has to do with the business model and who pays for this? And where's the return on investment to ostensibly the hospital system that pays for this? So where is the return on, because it's really all about reducing the cost. Sure. So how does this platform reduce the aggregate cost or the direct cost to the hospital in a value-based environment, not a fee-for-service environment?
Yeah, absolutely. So, there's the immediate sale is to hospitals to buy this as software as a service, with the idea being that they would save costs on running real tumor boards, they have to do them anyway as an accreditation requirement, and that they would be controlling their network, preventing patient leakage, disseminating care out, and keeping the referrals in-house, so to speak, for that hospital, if they're sharing these tumor boards with everybody in their community. In a value-based world, when we were looking at the oncology care model that first came out of CMMI and is now actually enshrined in MACRA as an alternative payment model, it specifies in order to get the quality bonus that you have to do some of the things that Oncoverse does for you. Did you collaborate with other physicians? Did you review the patient's information? Did you make the treatment plan available to the patient? And did you have involvement of multi-specialist experts? So we think that there's a sort of administrative, if you will, ability to check that box, providers to get their bonus and the hospital to get to that bonus. In the long term, about decreasing costs over the cancer episode, if you believe, as many of the physicians advisors who work with us have told us, the guidelines as currently written are maximum intensity care until death or remission. The savings then would be in personalizing the treatment plan to that patient such that it's not maximum care. Those avoided care episodes would generate savings on a personalized basis. So that's what we hope.
Okay. Well, thank you very much.
Great, thank you.
Appreciate it. Okay, the next company that we will hear from is Embodied Labs. And Embodied Labs has embodied virtual reality labs for healthcare training. This really resonated with me. I've done a lot of work in the diabetes space, and we spent quite a bit of time trying to make ourselves like patients with diabetes, with vision issues and neuropathy and other things to interact with products. So I'm really excited to hear more about your implementation.
All right, hello everyone. My name is Carrie Shaw. I'm the CEO and founder of Embodied Labs. So 10 years ago, I was 19 years old, college freshman. My mom was diagnosed with early onset Alzheimer's disease. About 5 years later, I was living with her as one of her primary caregivers, and that was when I was tasked with hiring her first home health aides. And so in addition to my mom's Alzheimer's, she happened to have this left visual field deficit. And so when I was training her CNAs, I would say, you know, it's not that she can't see out of the left eye like this, but she can't actually see out of the left halves of both eyes. And probably if I could see your faces without the lights in my eyes, you would say I'm glazed over. So I said, here, you know, this is the first prototype of embodied labs from many years ago. Put on these goggles. Hold on. Right? So immediately they could understand what my mom was experiencing. And they could feel, okay, I need to protect the left side of her body. If I'm going to approach her, it needs to be from the right. And, oh, now I understand why she eats exactly half of her plate of food at mealtime, and I have to rotate the plate so that she eats everything. And so this goggles is amazing, but it had one major flaw. It could really only simulate this one aspect of what is a much more complex condition. So I was working in public health education for a while, eventually went back for a master's in medical visualization. And I said, now I'm going to tackle this question. If we could embody our patients' perspectives, would this actually make us better healthcare providers? And that's where I met my two now co-founders. And, you know, this entry at an early age into aging care made me realize that we're actually going through a crisis in our country where we have so many people that are aging, yet we're facing a nursing shortage and really don't have the workforce in place to deal with this crisis. And so one of the ways we can see that is through turnover. Costly, really hindering our ability to care for our aging seniors. And so why is turnover a problem? Employees are burning out. They feel undervalued in the workplace. A lot of times the most important caregivers are direct force service providers. You know, they're feeling like the environment in their workplace isn't validating the hero-esque value that they're giving back to these patients. And really we see people burning out because they're not prepared to take on what is such a challenging job. And so what Embodied Labs does is we've created this VR-enabled software based around these modules where you put on a headset and embody the perspective of an aging patient. So we track engagement, we track confidence, knowledge, and we're seeing that this fosters communication. It's an open door to start a conversation. You have a common experience across an enterprise or a healthcare training program. You then talk about that and have something in common with what you experienced and a lot of things that are different. And so our product is a subscription-based software, and it's made up of this growing library of aging healthcare services training modules. And now I'm going to just jump right into a video and talk through that will give you a visual of how this actually works. So let me back up, and we'll get the video rolling. And so our customers are twofold. We have the academic customer who's in health services training, and more importantly, the enterprise in aging services. So right now, users get a 4-digit code. They purchase the hardware, download our application, log in with that code, and then they're able to access our library of labs. So we are planning to launch into single user sign-on and then see these labs automatically populate as we create more. We track metrics behind the scenes, and we also embed pre and post assessment. So we have a proprietary onboarding system we've created. It looks at what headset you have plugged in. If something's wrong, it'll tell you. You never have to look at the Oculus store or the Steam store. And then we have a self-facilitated onboarding process so that everyone can use this technology without a facilitator present. And so here you're seeing the Alfred lab. This is a lab around macular degeneration and hearing loss, the two most common aging impairments. You see you have 360 video around you, hand tracking and computer-generated objects you interact with. And then you get to go through several of these modules and the surrounding curriculum to really train yourself on what it's like to have some of these conditions. Now, our markets are, like I said, health sciences, education, and training, and then the aging services enterprise markets. We're really right now focused on long-term care. We have several growing customers there, and we've started to, with a partner 6 months ago that has been committed to using this training for 100% of their staff in a long-term care setting. And it's great. It's great. Thank you.
So I think you were just getting there, but if you could talk to us about what your business model is, who these customers are, if you already are at the revenue stage. Just a
Yeah,
little
so
background there.
our business model, again, is a subscription-based software. We're launching in June 2018 with a single user sign-on. A lot of our analytics features will then be tracked and given back in these instructor and end-user facing dashboards. And then what I think is the most encouraging is, so we're 18 months in as a startup, feels like 18 years. And we started out with several unpaid pilots in our first 6 months and have now, in the last 2 quarters of 2017, brought in $44K of annual recurring revenue. And I've just recently, since our launch of our Alzheimer's experience, which has 3 parts, you embody someone going through early, middle, and late stages of the disease, had just so much inbound traffic from the aging care space. We really started the company to create that lab, and we're happy to say that in the last 2 weeks since it launched, we've gotten incredible feedback from our end users.
One question about the content. How long does it take you to, how many content do you have right now, and how long does it take to create it?
Right now we have these 2 labs, macular degeneration and hearing loss, and then Alzheimer's disease. Within that, there's several more modules that step you through the content. Each core experience is 5 minutes long. We found that 15 minutes going through the pre-test, the prepare phase, the VR module, and the post-assessment is about right for both health sciences and training for employees. And so we create the content in 3 phases: pre-production, production, post. It takes us about 3 months right now to make a lab. We work with experts that work with the patients that we're simulating every day. We go out and do interviews with the patients and then look at the literature, and we create these interactive scripts and storyboards that can really become, it's a mix of a live action production and CG interactivity with lots of real-time rendering to simulate all sorts of things.
What regulatory and reimbursement rules need to change to make this scalable?
So right now, we're seeing that we can really get in where there's federal requirements for how you are training to work with dementia patients. So for example, in our current customers' workplace, they're replacing what they usually use, which is a web-based module that you press play and it reads to you for several hours, and you have 12 hours of that you have to complete. And everybody's trying to do it now that it's December. And they're like, oh wait, we can go downstairs, use an embodied lab, and then get some of that training. And they're like running towards the VR and saying, let's do this is fun. And then moreover, the whole company has gone through this experience and can just chat about it, whether they know each other or not, down the hallway. So I think it's going to replace what's already in existence of required training for people dealing with aging populations with different conditions. And then if you look at value-based care, I mean, you're already seeing those groups are training their physicians, their staff on saying, you know, you need to provide a good patient experience. So I think there's already the demand in that area. We're just not starting at that point.
I have 2 questions. So great presentation. I really like the market. I think workforce deployment and training, and there's just going to be a general shortage going forward, especially in the lower skilled roles in healthcare. That said, your customer base, long-term care facilities, perhaps post-acute care facilities, generally don't have a large willingness to pay, right? They have very, very small budgets. And although there is a need, how do you justify the return on investment to use a super forward-thinking and market-leading technology like VR as opposed to online videos, online training? So that's my first question. The second question is, when you think about your company, are you a platform company or are you a content creation company, right? Because the implications are very different in how you think about the business model.
Yeah, so to answer your first question, I had the same concerns in mind. And what really sold it for me was that I've had some inbound traction saying, I am a long-term care system with over 200 sites in the Midwest. That was one. 30 sites in the Southeast, 8 sites, again, in the Midwest. I want every single one of my sites to have this software for training. And so if you look at that, the beauty of a subscription model is that we can get what's usually content that's really hard to make, expensive. If we can share it with enough people, it's going to drive the cost down. One of our networks that we're working with, we've made a deal to say, you have all of these groups throughout the Midwest, Ohio, Kentucky, Iowa, Wisconsin, and we're working with them and saying that, if you all want to adopt this at Mass, one, we're working on some rev share models that really kind of promote spreading this technology throughout the systems. And then two, what I think is we're going to come with VR being widely adopted is the B2B2C. So they're already using this with their own residents' family members. They're saying, here's a support group, let's get them in this embodied lab. And then you tell them, look, this is what we use to train our own staff too. So think about holding community programming events. They have some motivation there because they're bringing in revenue for themselves. They could even charge for those events if they wanted to. So we're really trying to look at a group that also needs revenue streams and thinking about ways we can work together and bring everybody up at once.
Yeah, I thought the presentation was spot on. I liked it. I understand it. I really like the fact that you started with the team, because when we invest in a company, we invest more on the team than on the business, because businesses will normally pivot. That said, I'm concerned about the sustainability of the business. So once I get to understand how an Alzheimer patient reacts, once I get to understand what macular degeneration, is, or cataracts, whatever it is, I've now understood it. I don't really need to redo it again unless I have new people coming into that business and I need to train them. I think your comment is spot on about a platform or a content, and I think you really think you need to look at this as a platform so you can grow it, but where do you see the sustainability?
So yeah, I didn't get to answer that second question. And so right now we're working on creating some of this content, and what we're seeing is that as we simulate these different perspectives, we're creating things that can show what it's like to have these conditions, but then those things are all becoming their own assets. And so one of the big things in the VR community right now for content creation is how do we share assets so that other people can get out there and create things too. And so I look at the things that we're creating and saying, as we simulate these perspectives, these conditions, we have this bundle of, what is auditory processing going to be like? What's the code there that alters that? What about if you want someone to speak and you're simulating language processing problems? That's in our Alzheimer's lab. So it goes beyond just, a simple, here's a visual challenge. It's what's early stage macular degeneration and late, or retinopathy, early, late. And then, who else wants to use this? Clinicians who want to encourage their patients to adhere to their drug regimen. So, you can then take the assets, maybe take some of the content, the 360 videos, and create your own patient intervention tool down the road. I think the reason why we've chosen to start where we have is because that is where we can get in the market, we can get revenue, and we can create these things, and there's a whole host of other things that will come as the medium takes off.
And one follow-on, how much revenue do you anticipate over the next 1 year, 2 year? What's the growth pattern?
So I anticipate, right now we have contracts in negotiation for $150K, so we're going to close that here in the next few months, and then I want to get to $500,000. I'm being very realistic here. $500,000 by the end of 2018, $1 million in year 2, do our Series A, and then we're going to scale, because where VR hardware is going will mean that we will no longer have to deal with all of the cords and the bulky technology.
Think bigger. Think how to get, seriously. Think about, put a BHAG out there, a big, hairy, audacious goal of getting to $10 million in 3 years, and then do a Series A, or sell out before then when somebody says, well, they're really on a great growth path, and I'll buy them out at a good multiple. So that's just some advice.
I'm going for it. I'm always trying to think bigger.
Absolutely. Yeah. Thank you.
Good job. So our next presenter is Geneticus.
Hi, I'm Vineet, and I'm here with Geneticus. We're a clinical stage medical device company headquartered in Cincinnati, Ohio, and we are using cardiac magnetic fields to optimize triage of acute myocardial ischemia. Over 10 million Americans suffer from chest pain every single year in the United States. And the issue is in determining whether that chest pain is cardiac in nature or not, whether it's true myocardial ischemia or not. Physicians are working with really expensive tools that are rather confusing and very time intensive to determine whether or not that patient has myocardial ischemia. Basically, in the status quo, patients subjected to 16 to 18 hours of tests. There are a battery of different tests that are performed that all in all have pretty poor outcomes, both clinically and economically. Clinically speaking, there's a high number of false positives and false negatives, and from an economic perspective, hospitals are losing thousands of dollars per patient admitted to the emergency room for observation status. For example, in the Midwest, a stress test, stress echocardiography, costs over $2,600 to do and can only be done 8 to 12 hours after a patient is admitted into the emergency room. To solve this problem and improve clinical outcomes, we've created the Faraday, a first-of-its-kind, full-stack biomagnetic imaging device that uses artificial intelligence and machine learning in order to get to the decision of definitive discharge or further treatment in a fraction of the cost, in a fraction of the time, and with as high or higher clinical accuracy as existing diagnostics today. In general, this device works entirely non-invasively. There's no contact. The scan is simple and easy to take, and on top of that, the scan itself lasts only 60 to 90 seconds long. In general, we're enabled to do this because of our use of artificial intelligence and the uniqueness of the data that it is we're able to collect. The magnetic field data that is naturally emitted by the heart is collected by our device, and the data itself is incredibly spatially and temporally rich. As a result of that, we're allowed to take advantage of several multiple parallel pipelines for actual imaging, and for each of these different imaging pipelines, we're able to extract several different unique features from them and actually train neural networks to understand the difference between normal and ischemic tissue. In practice, when we actually have done clinical study, we've been able to see that there's a very tight distribution of normal patients versus abnormal patients, as you can see in the images behind me. The most important thing to remember, though, is that we have AI-enhanced imaging, which means we are enabling clinicians to have automated image interpretation when it comes to all this, to avoid any additional clinical glut in the system. As a result of this, what this basically means is that all images that we are generating are the basis for any artificial intelligence diagnosis, allowing a sort of environment of trust but verify for clinicians who are seeking to make this diagnosis. From a financial business model perspective, we are able to offer great economic outcomes as well, because in terms of an actual per use of the device, we're charging a fee that is 10 times less than what the average recurrent revenue costs are for a lot of different devices out there. At a $250 price point, we're poised to change the marketplace. I can get to some of the other questions about financial models later when we get to the Q&A, but I definitely want to talk about the scalability of our platform. Because as of right now, we are focused and laser focused on an acute platform. But as our intelligence, sort of machine learning and artificial intelligence models grow to a point where we can get to predictive-based modeling and more general intelligence, we plan to move this into an ambulatory setting when we're talking about a situation where this is sort of a common part of the workflow for a primary care physician or for an urgent care center. Eventually, we've looked to scale to other cardiological applications as well, and because the heart is not the only organ in the body that emits a magnetic field, we're looking to scale to neurological, fetal, and gastrointestinal applications as well in the next 5 to 10 years. In general, we're powered by a great team. We have 16 people right now at our offices in Cincinnati, and in general, we've been fortunate enough to have $2 million in Series Seed capital so far, and we're currently closing a $5 million Series A round. We were also honored to be named last year's NVIDIA's top startup using artificial intelligence for social impact. We were lucky enough to take away the #1 prize there, the grand prize there, and it's really fueling us to continue to work on building this application, right? So at this point in time, we're all laser focused on using both biomagnetism, which is a new form of imaging altogether, and artificial intelligence to really shift and change the paradigm in medicine as it stands today, in order to allow clinicians to make decisions more confidently, more efficiently, and more effective than ever before. With that in mind, I'll go ahead and give the rest of my time to questions. And before I do, I'd like to also introduce Raj, who is basically our machine learning engineer right now, to also join me if anybody has any specific questions related to how we do artificial intelligence. Thank you.
Okay.
What is the regulatory approval status of this?
Yes, so the device right now is currently an investigational device. We will be getting regulatory approval by mid to late next year. That's when our full commercialization is. It's a Class 2 device. We've already talked to the FDA and gotten agreements on what the test plan looks like, and that's pretty much a 510K process for us.
It's a Class 3 device.
Class 2 device.
I'm sorry. So it's a 510K
Correct, yes.
process.
Mm-hmm.
And the predicate device is?
So the predicate device is a now defunct form of biomagnetometer called the CardioMag imaging system. That company went defunct probably about 5 or 10 years ago. But in general, the new thing that we're bringing on, and really the new value add that we have, is we're the first system that is entirely non-cryogenic and driven by its software in terms of making the clinical diagnoses.
And the FDA will not require you to do a clinical trial.
So they require us to do clinical comparison data basically on 7 different patients head-to-head against the predicate device versus this one. And the idea is the current clinical trial we have right now is 120 patients, and it's really looking to tell more of a health economic story and get initial data for a more expansive clinical claim set later on at the end of next year.
Interesting. What assumptions have you made around the capital equipment sale? How long do you think it will take?
Right.
As
So,
capital
based on
equipment
the
has its
clinical
own
data,
challenges.
yeah, exactly,
Yeah.
right. And I definitely appreciate the question, right. So, based on the current challenges we've seen in sort of emergency room settings and emergency room directors, what they're basically saying is that if this device is able to work properly, it'll be on the shorter end of their capital sales for something like this. And the sticker price for this device is around $400,000. This is a sales cycle that'll probably last about a year long. In terms of the actual time it would actually take to get into a hospital. But many of these clinical sites, more importantly, have been very open in accepting this $250 per click model that we've been talking about, which is good news for us and them as well, because it means that they can recoup their investment within the course of the first year of actually operating the device, and we'll also, as a result of that, get to see the same benefits and same upsides.
Yeah, first of all, I thought the presentation was great. You hit all the checkpoints that I would look at for an investable opportunity. You obviously have done this before if you're going in Series A,
Yes.
right? So you're very articulate, you present well. Where are you going to get all the capital to fund all these machines that are going to go out to recoup it at $250 a pop?
So as of right now, our Series A plan is really to get to a commercialization standpoint where we'll only really have 3 devices out there. We're planning to raise a Series B towards the end of next year at around $25 million, a lot of which will be growth capital and also investment into other different opportunities, basically. So there's other use cases I was talking about, different organ states, et cetera.
Great presentation, guys. It's a very disruptive technology, but in line with disruptive technologies is there's usually problems with clinical adoption. And so, how do you think about getting clinicians to change their practice pattern behavior? I understand the economic argument, but how are you thinking about kind of mitigating some of those risks around clinical adoption and getting clinicians to change their practice behavior that they've been practicing for 10 to 20 years and have trained in such a workflow?
Right, that's a great question. And I think there was a general sentiment throughout this entire conference of data is key to all this in terms of making sure that we sort of continue our clinical strategy and be aggressive in terms of how we're actually tailoring that clinical strategy to reach the widest number of emergency physicians out there. And more importantly, show them that with the device use, you can save time in your observation departments as well as improve outcomes overall. That's really sort of our big strategy in terms of pushing this device really is something that's going to be game-changing. But thank you for that question. Hopefully that answered it.
What do you see as the biggest threat of the substitute? I mean, given the advance of AI, given the advance of bigger, smaller, cheaper, faster, given the advance of mobile technology, if someone has chest pain in the field, somebody's going to go out and see them, and presumably someday, if you believe what we're all talking about, somebody with an iPhone is going to put it on their chest and it's going to tell them whether they had a heart attack or not. So you can do that for less than $400,000. So my question is, I don't know whether that's going to happen or not, but my concern is threat of substitutes. And
Sure.
given the long sales cycle, given all the capital equipment, given all the issues, are you concerned about that?
No, that's definitely a great question. The point of the matter is that with this new form of imaging in terms of what we're looking at, which is really biomagnetic signals and biomagnetic measurement, this is the first of its kind in terms of being very, very sensitive to disease from what we've been able to understand from the current scientific progress out there. You're entirely right in that one day we're moving towards a more mobile economy where these sorts of things are going to happen. At the end of the day, the device that you see in front of you is simply a stepping stone. We already know what has to be done to eventually get that from a large piece of capital equipment down to something that can be transported, moved around, taken to the field, as you sort of say. Now, arguably, that's a time investment on our end and a capital investment on our end, but realistically speaking, that's what it's going to take, I think, for us or any other technology out there right now.
Thank you, Vinny. Can you give us a snapshot of your IP portfolio, and are there applications outside of cardiac ischemia that you see?
Absolutely. So to answer the first question, when we talk about IP portfolio, we have the luxury of having sort of end-to-end coverage on our IP, at least protection that is pending right now. We have a granted patent that covers our analysis methods on the back end, and we also have a patent that's pending right now on both artificial intelligence and the utility of using a device that basically uses front-end magnetometers like we have for biomagnetic detection, combined with sort of the use of some sort of shielding. So that's really where the core IP lies. It's sort of end-to-end coverage in that direction. But beyond that, I guess the second question you talk about is applications beyond cardiac ischemia. We actually founded this company with the goal of creating better and non-invasive pre-surgical mapping for ablation, right? So cardiac EP and that sort of a thing. So that's definitely a focus region where we're going down. But also we see different applications, for example, with neurological applications and fetal applications. So for fetal, assessing the unborn heartbeat, right now it's a big problem where high-risk pregnancies, even though it's sort of a smaller market than chest pain, high-risk pregnancies are an issue because it's difficult to really assess the fetal heartbeat and after the second trimester push drugs and understand what the impact of drugs are on the fetal heartbeat. From a neurological perspective, there are applications right now for ischemic stroke as well as for pre-surgical epileptic foci mapping. And we sort of walk in the shadow of other people behind us who had, older systems that were more meant for research-based applications in the sense that they've already developed some applications for this, and we're really the first to bring this to a commercial setting. That's really what we're blazing the trail and being able to do here.
I have a question about, you mentioned, thank you, good presentation.
Thank you.
You mentioned AI multiple times.
Mm-hmm.
So can you articulate what part of AI is critical to your visualization and what part of it is more on the interpretation side?
Mm-hmm. So
it seems that you need some form of representation to begin with because the way you capture image is different.
Right. So you're right, and you're very astute in pointing out that the majority of the AI work happens more on the actual end of the interpretation rather than the actual imaging. The imaging is done with slightly more classical techniques, but beyond that, the point is that with the actual interpretation, I can let Raj touch on this more in detail, but we actually are able to look at unique image features that for other situations, if you were to look at it entirely by eye, it was said earlier today that in general, artificial intelligence enables for faster diagnosis and more accurate diagnosis if you are looking at images rather than some other form of data. So I can let Raj touch on that more if I haven't really answered your question, but in general, that's the...
What kind of additional data do you require to build your machine learning capabilities? Is it just based on the imaging technique or you have to capture additional data?
I don't think we need any additional imaging. We just need what Vineet showed in the slides. We have like different imaging techniques. So what we do is we have like a voting classifier kind of thing. So we have like a magnetic field map. We saw another stag, which was like the activation map, and we saw the face-based features. So we use all those three features going into neural networks simultaneously and parallelly, and then what we arrive is we have those features coming out of the neural networks parallelly and use those three independently and try and come to a conclusion whether all three of them agree that it's an abnormal case or it's a normal case. So what comes out of the neural network is like the visually important features for deciding whether it's a normal or an abnormal case, and all those three should ideally coincide and say.
How advanced is it right now? Do you have to capture more data moving forward? Do you have to do more trials to have robust systems, or what's the confidence level right now?
So as of right now, you saw the actual graph earlier in the actual slideshow. We've been able to define what normal looks like. One thing that we're really working on and trying to acquire more data to actually figure out is what exactly does abnormal look like, and more important, how do you stratify that further? So this current clinical study that we're looking at right now tracks, for example, the level of stenosis in a certain patients, the level of blockage in different coronary arteries. So this is, for example, another thing we're trying to bring in to add additional feature sets to the actual artificial intelligence. So right now we're talking about a situation where we have roughly 300 cases or so of information we've been using to train our models, plus tens of thousands of sort of simulated cases that we've been able to use. Beyond that point, though, basically, is we're looking to scale this into a 1,000-patient multi-centered trial where we're tracking more health economic data as well as specific data regarding diagnoses, level of stenosis, for example, medical outcomes, that sort of a thing, follow-up for these sorts of things, to really build the model further on the end of positive predictive value and sort of build it on the end further for what exactly does abnormal look like and how can we further stratify that to enhance analysis.
Thank you.
Okay, thank you.
Thanks.
The next company that will present is Javion, and they have a cognitive clinical success machine. One of the things that I'm interested to hear about is how they're able to predict things like pressure ulcers and avoid those kinds of incidents and save the system money. So please.
Thank you. Thank you. I'm Brad Allen. I work as the regional guy with Javion. Javion's based in Atlanta, Georgia, and we've actually been in the market about 4 years. Javion's solution to the market is we've designed a cognitive machine that's focused on reduction in adverse patient events. So if you're a hospital, all the hospital-acquired infections, sepsis, C. diff, you name it, right? If things like pressure injuries, fall risks, and then as you move to the ambulatory setting, looking at population health, chronic disease reductions, and identifying those patients most at risk for a heart attack, those patients who are pre-diabetic, most at risk at advancing, and that sort of thing. So that's really kind of the crux of what we do. There's really three key components that distinguish us. It is a cognitive machine. I'll start with the kind of how we do what we do. The first thing to note is we purchase a lot of data. We buy a lot of publicly available data, Census Bureau, credit agency, weather data, environmental data, and we store it in the cloud in our environment, in our platform. And what we need to know is who your patients are. Once we have that, and we can get that from generally a readily available interface that's already developed, pull in those patients and any clinical information you happen to have, laboratory results, medical profiles, medication profiles, et cetera. Once we pull that in, that allows us to place those patients in our environment. It's built on an EigenSpace platform, very similar to Google and Amazon. With that, we can infer a lot about that person. And with that, that information, then we can predict kind of where they're headed in terms of their health status and whether they're heading towards an adverse event. So each of those adverse events we call vectors. So we call them clinical vectors. And in the end, these vectors then allow us to specifically identify those patients that are most at risk. We deliver that back to you with a list of recommended interventions for those patients that then feeds back into your EHR. So we've integrated fully with Epic, Cerner, Meditech thus far. And this is just a list of some of our clients. This is about 6 of the over 40 clients we have today. It represents about 250 hospitals. And the numbers you see are the dollars they've accounted in terms of cost reduction and cost avoidance by using our system. So in a lot of cases, it's things like avoiding the penalties of readmission, coming back, a pressure injury. It's estimated to cost about $43,000 per episode. So the return on investment is enormous. If anything, we're probably not charging enough for the system based on what our clients are getting back in return. But that said, we're happy with the results and that we're having a positive impact. Obviously, there's also a great impact for the patient with this. The second point is that it's built to think like a human. It's a cognitive machine. It's, again, using this EigenSpace platform, and this is the same technology that was used by Google and Amazon. And a lot of that has to do with the heritage of our founders. They worked for a search engine company that ultimately became the Google search engine back in the late 90s. So that they took that knowledge, that expertise, they brought it to healthcare, and they were smart enough to also bring in some clinicians as well to bridge the gap. Simply put, once a patient hits the EigenSpace environment, we can identify their direction and speed towards an adverse event, and then we can introduce the green lines or interventions that we would recommend that would help to alleviate that patient moving and move them towards hopefully not incurring that event. So that's really in simple format how the system works. The third point is that this is really created as a platform. It's an investment asset. So there's really two components. Well, with that.
Great, thank you.
Maybe you'll get a question on that. So you mentioned that the company's been around for 4 years.
Right.
When did you start generating revenue, and what has that revenue ramp looked like?
Yeah, so we are at about, our business model, I'll just point out, is a monthly subscription. We do that by vector. So typically, there's an upfront fee. It's a low six-figure to set up the machine and fine-tune it for that particular client. And then there's the monthly subscription for the vectors. Right now, we're really closing in close to reaching the $1 million per month monthly recurring revenue at this point. So that's kind of where we're at. We're not quite there yet. Hopefully, we'll be there soon.
As we've had some conversations, but as AI becomes commoditized, and I think we've had this conversation prior to this, but we'll just discuss it out here. So fast forward, call it what you want, data science as a service, AI as a service, whatever we decide to call this. Pretty soon there's going to be lots of roll-ups and lots of people that are sort of commoditizing predictive analytics. So my question is, what is going to differentiate the best from the rest when you're basically buying a commodity, or put another way, what's your sustainable competitive advantage?
Well, I think what I didn't get to in that last slide was our speed to value. And typically from contract to actually usable risk predictions and intervention recommendations, it's about a 3-month process. So, and there's also a pretty low cost up front. So those are our advantages. We see ourselves as kind of that invisible resource behind the scenes. The ideal implementation is to be integrated back into the EHR, into that clinician workflow for nurses and a case manager if they're working on an outpatient population health type application. With this platform, I've been with the company 18 months. We had 34 different vectors. At the time I joined, we now have over 55 vectors. So it's very extensible, and I think there's a lot of stickiness to it. So once it's in, it's very hard to give it up. And thus far, we haven't seen anything else like it.
Great presentation. I know Javion, I know some of your existing investors. We've invested in a number of analytics companies, and ultimately, one of the kind of the biggest roadblocks to kind of creating big businesses and analytics companies is that you're not necessarily selling analytics, you're selling an outcome, right? You're selling a solution. And ultimately, how do you intervene? How do you kind of get interspersed into the workflow to drive the outcomes that ultimately that you are guaranteeing? And then furthermore, from your business model perspective, have you thought about kind of putting some of your dollars at risk to kind of guarantee some of those outcomes, to ultimately increase the potential total value proposition? Ultimately, you've shown, I think it was, I don't know if it was Grady or another hospital, where you've delivered $6 million of value over a 3-year period. You've only collected $300,000 to $400,000. How do you not leave some of that value on the table?
That's a good point. So at this point, with those case studies that I showed you, we obviously that helps us to sell. It gives people confidence in the system. We're not really, we haven't had the need to go at risk, I guess is the way to put it, that because of the low entry cost. At times we'll negotiate on that upfront fee, but in terms of once we get into the monthly subscription, we're able to demonstrate the value. Now, if it doesn't perform, and our CEO is very adamant about this, if people aren't getting value from the machine, he doesn't want them to pay. And he's stood up for that at times when we've had a hiccup due to some event that's out of our control in some cases. But that's, like I said, that's kind of a rare case. And
just back to my first question, how do you intersperse yourself into the workflow? How do you ultimately get your clients to intervene on all of the analytics and all of the predictive modeling that you're pushing forward to actual clinicians in the field?
So that's one of the early learnings of the company. There was a group of data scientists. They went out, they said, oh, look at this, it's amazing, look what it'll do. And they ran out, and then it just dead-ended at the client because nobody knew how to get it out to the workflow, right? So that's when they got smart and hired some clinicians. I was going to show a quick video of our chief product officer, but he was the CHIO at University of Mississippi Medical Center, Dr. John Showalter. And Dr. Showalter is now on board, as well as a number of nurses and a former CNO as well. So that's what we've learned, and that really makes a difference, because once you get those colleagues talking, and we have champions on the other end that are clinicians, then the rollout's much smoother. We have who we need to make it happen. And typically, it's, the ideal, again, is that we're not changing workflow. Where they may be using something like, for pressure injuries, the Braden scale today, that'll just be replaced, or they might just add a column to show our risk score, and then the intervention recommendations would come after that.
I guess that's my question. Is the output a score, or is the output an action? It's a directive
Both.
to the clinician.
Yeah, so they show up as either a numerical risk, or in some cases our clients just want to see high, low, medium, and then behind that comes the intervention recommendations specific to the individual patient. We are able to measure their propensity to engage in specific interventions through the tool. We've got about 20 million patients in the platform today, so the machine's just going to get smarter and smarter as time goes on.
Where is the AI versus the big data? I'm hearing big data, and I'm thinking a competitor is Watson. And that's the first question. And the second one is, what's preventing you from grow quicker because the outcomes are so good relative to the cost?
So the AI is really that ability to take a new patient and place them in the eigenspace, and then whoever they are like, we're going to be able to infer a lot of information about them based on those people that they are like. So we have about 5,000 different elements that we can apply, and for any given patient, there's probably over 500 on average that we can apply to that patient, and that tells us a lot about who they are like, and therefore what trajectory they're on. So that's on the AI side.
And what's preventing you from growing faster since you had such good outcomes?
Right, so where we're at, I didn't get to that. So we are going out for Series B in first quarter this year. They will be at the JP Morgan event and in San Francisco. We're a finalist for the Accenture Health Tech Innovation, which is also occurring during that same week. So that's going to be an important milestone for the company, and we hope to raise somewhere in the neighborhood of 25 to 30 million.
I just want to piggyback on Dan's comment, and that is that the Holy Grail is not to deliver information. The Holy Grail is to change behavior. And if we're really not going to make much progress unless we can change doctor/provider or patient behavior. So in general, information does not change behavior. There's another step, and that step is very difficult. And there are lots of ways that you can try: gamification, nudging, emotion, economic, tricks, all kinds of stuff. But the problem is getting people like me to change their behavior, even if you give me this information. So it gets to your point. Okay, I know this patient has a 36% chance of developing a decubitus ulcer. What am I going to do about that? And how are you going to motivate me, reward me culturally to change the behavior? So I really wouldn't underestimate how important that step is.
And how hard it is.
And how hard it is. Data does not change behavior.
Right.
You don't lose weight because you get on the scale every day and measure your weight.
So on that note, I just want to mention an intervention that one of our clients came up with. I may have mentioned this to you earlier when we spoke, but at Grady Health in Atlanta, as most of you know, they're like the safety net of Atlanta. They came to us and said, hey, we want to prevent those discharge patients from showing up in the ER within the next 30 days. Big problem for them. So what they did, the intervention they came up with, was take an ambulance driver and an intern and put them 2 days a week, and they are just doing house calls on those patients. And they've reduced their incidence of those patients returning to the ER by over 30%. So those are just some innovative ideas that come out of it, and it's helped those patients, right? And then the kind of side effect of that was they got some good PR driving around doing house calls.
Great, thank you.
Okay, perfect. Thank you.
So our last presenter is Featherlink.
And I just learned that apparently you're going to be running for the airport.
Yes.
So we won't have time for questions.
Okay.
With Sophia after
Wow.
her presentation. Yeah.
Hi, I'm Sophia Wickland, and I'm founder and CEO of New Sun Technologies that makes Featherlink. I've been founder before many times. I'm a serial entrepreneur, and I have a history of successful exits. Right now, I'm a co-founder and an advisor of Silicon Valley Deep Learning Group. Silicon Valley Deep Learning Group is a 5,000 members group in Palo Alto that specializes in startups in artificial intelligence and deep learning. Also, I'm an investor. I'm a part of Band of Angels, which is a very prominent Silicon Valley investment group, and also Golden Seeds, which invests in women. My previous work had to do with behavioral analytics for human decision-making in high-stakes environments. Let me go to the next slide. How do I do this? All right. So my team, I'm so proud of my team. They are the best. One of the members of my team worked on Google's, what's now Google Waymo. He worked on the first self-driving car that is now Google Waymo at Stanford. My team members worked in leadership positions for Apple, for Google, for NASA, for Johnson & Johnson, Kaiser Permanente, and other companies, including Intel. One of our senior engineers launched Mars space missions for NASA. He's a rocket scientist, but his biggest exit was helping Jessica Alba launch her mother and baby honest company. So I'm very proud of that. Our advisors include founding CEO of Udacity, so a big company. We also have people that work at Stanford, they're Stanford professors. We have a senior advisor that was co-founder of LinkedIn, and also one of our very senior advisors advised Steve Jobs for 20 years to bring Apple to 800 billion status. So, but since this is a medical conference, let me tell you a personal story about a doctor. So who is this doctor? Who is this doctor right here? This is my mother. She's been an eye surgeon for 40 years, actually over 40 years. She had a long medical career. And a few years ago, she was diagnosed with late stages of cancer. None of my family members actually knew what was going on prior to her being diagnosed. And I work in tech. All the rest of family members are doctors. So none of us knew what was going on with my mother. So it's been a year and a half of her behavior that actually changed until she got the diagnosis. So that came as a surprise. So the company that I have right now was inspired by my mother's story. I want to save lives, and I want to help other people save lives too. So the company that I've started right now has to do with behavioral analytics to predict an early onset of critical medical conditions. And why do we do this? We do this so we can help people. Well, we can save lives, of course. I wish my mother could still be around. She could live for another 10 years if she'd have an early diagnosis. But we also want to save on healthcare costs. Imagine how much money people could save if something like major disease has an early onset of such diseases diagnosed earlier. So what happens usually is that disease is diagnosed too late, and we can't really treat it effectively. So my company uses deep learning and artificial intelligence. We use state-of-the-art systems that uses classification engine. That engine takes data from cell phones. Just like what you have in your pockets right now, smartphones. We have Android phones. We we have Apple phones and any other cell phone. There is third-party clinical trials that prove the efficacy of our system. You can detect by using cell phone data major clinical, major disease like onset of major depression or bipolar depression or other conditions. So our idea is based around analyzing person's behavior. And let me finish quickly. We want to quantify, we want to save lives, first of all. That's our problem, that's our mission. And also we want to improve patient outcomes through making sure that people have better experience and there is an early detection of large problems that will save lives. Thank you so much.
Thank you. Thank you. Get to the
Thanks.
airport.
And
Hope
thank
you
to the
make your,
conference
hope you make
organizers.
your flight.
Thank you so much.
Right,
Okay. Well, we need to do a little voting
right.
here.
Yeah, so we need to do some voting, and then we'll tabulate the results, and we'll
Yes.
come back with them.
And while we're doing that, perhaps we can go around as a panel and maybe give a tweet or a little bit of advice to physician entrepreneurs or other entrepreneurs in the audience. So I have voted, or I'm trying to vote. And I can start. You can
Yeah,
jump
go
in.
ahead.
And I would suggest that people take a look at the lean startup methodology if you're starting a company. As physicians, for the physicians in the audience, you're on the front line, you're the perfect people to be able to see the problems, to envision solutions, but it's also important to recognize that how your institution works, how your practice works, may not be reflective of all the practices across the world. And what I particularly like about the lean startup methodology is the insistence that you go out and talk to a lot of people, that you get input from different customers, and you get beyond your bubble. So that would be my advice. Want to jump in?
So in my work with physician entrepreneurs, and it's an open innovation network, so there's a couple of things. I mean, you've already sort of inferred the kinds of questions that investors are looking for when you're pitching, and there's a whole art to how you pitch, what you say, what are the questions, time, and all that business. But I think fundamentally what you're really trying to do is to come up with a decent value. I mean, understand, I guess if I were going to give a headline in the tweet is, be a problem seeker, not a problem solver. And by that I mean there's two major reasons why most businesses fail. One is they make a product that nobody wants to buy, or they try to sell it using a non-viable business model. And those are really the two critical questions, either early, middle, or late stage, because it's always changing, that you need to understand. And the only really way to do that, as was mentioned, one way to do it is to go out and talk to folks, but you really have to have a lot of environmental sensors to sense when the market's changing and when you need to so-called pivot or change your approach to how you're going to doing things. So again, don't make, seek to understand before you want to be understood. So you really need to kind of do a deep dive into the market. What do people want? What's the jobs, pains, and gains they really want you to do? All that sort of value proposition design stuff. And the problems that I see the most, and I'd be interested in the other group, is you make a product that nobody wants to buy. And there's a general reason for that, because the dog doesn't want to eat the food.
I think just, kind of writ large, our investing philosophy is we invest in great people going after big markets, right? Big problems. So I'll talk about the second one first and then get to the first one. Arlen was talking about, kind of market and ultimately willingness to pay. I think it all comes down to the value proposition of your product. And I think the only way that you really understand the value proposition is by talking and spending time with customers. You may have been a customer before, you may have customers who are advisors, but I strongly recommend entrepreneurs to spend time with your customers. I think that generally speaking, entrepreneurs are very focused on their own business model and not focused enough on their customer's business model. right? And how they interpret value, from a customer perspective. And so I think that's really, really important. I think the second piece, in regards to team, I think as a former entrepreneur myself, oftentimes, entrepreneurs don't have a lot of resources, and so we look at the best of what's around, and that's how we build our team, whether it's, friends, whether it's family members, whether it's people who we know. I would encourage all entrepreneurs to try and stretch. And work with your existing networks to find the best possible people that you can recruit to an opportunity. And that, again, I think all of us individually are incomplete. I mean, sometimes we can probably be the jack of all trades and not only be the tech person, we can be the salesperson, we can be the product person, but really focus on your core competency and work with other people who have complementary skill sets to your own, also complementary networks to your own, to ultimately kind of build out a full team.
The two that I would say is after seeing a lot of companies, and I know they couldn't do it here in 5 minutes, but really kind of saying where your value proposition is and your competitive advantage, right? So know your market, know exactly how you're going to get your strategy done. The second one I have is around the companies that are hardware-based. Med device traditionally is very costly in terms of maintenance, in terms of getting that approval process, so kind of addressing that up front and being able to say how you're going to get in front of that, especially in a world where AI is just consolidating data and they have no hardware cost to contend with.
Yeah, you have not left much to say, so I'm going to try add a few nuggets. I think the fundamentals of the business are always true. At the end of the day, there is a need for a problem to be solved, and that has to be articulated very clearly up front. And the mechanisms for that problem to be solved should also be explained. And we can call it business model, product market fit, workflow, whatever we want to call it, but that nugget is very important. Because we're entering an era where automation and machine learning and all the technologies, and we have said it before, will become mainstream, almost on demand available. I think the addition of AI to any business might not make any sense in 2 years from now, or a year from now, or 3 years from now. I cannot just pick a guess, but it will become very obvious that everyone will use some layers of intelligence, whether it's cloud-based, whether it's on-demand, whether it's services-based. So the opportunity, I think, will be to work on very hard problems, more than just obvious problems, and try to understand the domain problems that have not been surfaced yet, and how new technologies can actually solve the problems that we were not able to solve yesterday. So instead of going faster or stronger, is about shifting and understanding what are the type of problems can new innovations such as machine learning can actually solve that we're not able to solve before. And that would be an interesting approach to get not only funding, but also to solve hard problems going forward.
Yeah, it's hard to add to what was said because all the points are well taken. So I'm going to try to give you a paradigm that may help put it in context. And context is an important word. Number one, you have to understand the competencies upon which you're building your company. Number two, you have to really understand that there is competition. Even if it's pad and pencil to AI or prior knowledge to new computer technologies, there always is competition. There's another service out there. There's another way to do things. Don't minimize competition. It's killed many a company in the past. The third one is customers. You can't overestimate or underestimate the ability to go out and find what we call lead customers, these lead users, the ones that have the problem, they're trying to solve it before anyone else. Find them, use them, bring them on your product advisory boards and all. But one of the things that has to be done real early on from an investor view is put it in context. You need to say something early to grab our attention so we really understand what you're up about, what your problem, what the problem is, what you're trying to solve, what the differentiation is. And I like to teach my clients the following. Use the words like, unlike competition such as blank, because that gives an analog, it gives you some comparisons. We do it this way with this technology and do it with these kind of results. So really it's the 4 C's: customers, competencies, competitors, and context.
Okay, thank you.
Great.
I don't know where we are.
We're going to I think what's going to happen is he's collating the results for the award.
Okay.
But while we have some time, are there
some
questions
questions, yeah.
questions from the audience, either generally or specifically about any of the companies?
It's hard to see.
Yeah.
How many of you had a lot of drinks and then you're just,
Yeah.
just
And it's
curious?
dark.
Anthony, do you have a question?
We're there?
Oh, yeah, put that question up on a platform if you can do that.
Yeah, we have the questions.
And, you know, maybe one question is, you know, what is your biggest challenge in getting an idea to a patient? If you're an entrepreneur, if you're someone that has an idea, you don't know what to do with it, you're not sure what to do next, where do I find money, et cetera, what's your biggest challenge?
I mean, I'll just, you know, throw out a question, you know, and I'll answer it. So,
And then we have the results.
Yeah.
what are the roadblocks to you know, startups who are working on AI in healthcare to raising money? I think that for the last, you know, kind of 4 or 5 years, you know, many of my cohort, you know, venture investors have invested in a lot of AI and healthcare companies, and I'm sure you guys know a lot of the names, and so I won't repeat them. One of the big problems has been, you know, gaining traction. I think that, you know, to some of the earlier comments today, that there's a lot of early, quote unquote, early adopters who will, quote unquote, pilot your technology or use it for free, and so you get to put their logo on your slide deck as an early customer. But it'll be very hard for them to migrate from pilot customer to, you know, large customer, large recurring revenue contract, simply because the use case hasn't been honed, right? That you're not creating enough value. You know, I think Arlen pointed out before, one of my favorite you know, kind of senior advisors, senior operational executives at a healthcare company has piloted a lot of these technologies. And what he says is, I get a bunch of lists. That's all I get from these technology companies. A bunch of lists of patients who are, quote unquote, at the highest risk for X, Y, and Z, you name it. There's an AI model to predict it. But ultimately, they're not delivering on the outcomes. They're not delivering on what the expected solution is. And so I think a lot of the AI and healthcare companies have to go a bit further. They have to incorporate this dreaded word called services sometimes, you know, and actually to, you know, intervene on a perceived phenomenon. And so that's just a trend that I've seen. A lot of, you know, early adopters of AI in healthcare and early stage companies who have built a lot of really, really great product, but are not actually, you know, building the big businesses that they had projected in their pitch decks.
So my experience with that is there are 3 big barriers. One is integration into the legacy EMR. 2 is finding a partner, a clinical partner, and not winding up in pilot purgatory, where exactly what you said, but the project just sort of dies. And the 3rd is even if you succeed in demonstrating a successful endpoint with a pilot, then overcoming the barriers to adoption and penetration. And to a person, non-sick care entrepreneurs, that is technologists that come from a different domain and think they can solve sick care, have a very hard time understanding how difficult it is to overcome those barriers to adoption and penetration. They vastly underestimate the time it takes for things to scale in sick care. And I call it sick care because it's most of the 3.3 trillion is about taking care of sick people, not making them healthy.
Yep, sure enough. Well, we have our
Yay.
winners, so let's.
Okay, so.
Okay.
Drum
Yes,
roll,
really.
yeah, right.
Would you like
So-
to announce our 3rd place?
Right, so drum roll,
finisher?
please. Our 3rd place finisher is Embodied Labs.
Yay. We'll have them come up. Can you come up, please?
Okay,
There
so,
she is.
cool.
That's impressive. They already framed it.
Yeah, they already have it framed.
There you go.
Jeez, that is impressive. All right.
Congratulations.
All right.
Good job. Thank you, yeah. Thank you.
Go ahead.
Okay, our number 2 finisher is Javion. Please come up and join us. Thank you.
Good job.
Congratulations.
Right,
Very good.
Okay.
Thank you. And our number 1 finisher?
And our number 1 finisher is Geneticist.
Hey. Thank you.
Congratulations. Right,
Thank you. Let's get you guys in the middle.
right. Yeah, you get over here.
We'll surround you.
Right.
There you
Okay, great.
go. Okay.
Okay, so let's give
Congratulations.
everyone a big hand.